Welcome back. It is the last week of term, and I know this because this is my last lecture of the year. It might not be your last lecture of the year, but it's definitely mine, and so that's cause for celebration. 2, it's definitely a year since we went into lockdown, and I know this unequivocally because last year, the first part of these lectures was the last lecture I gave in the John Hanbury Lecture Theatre. It was on a Thursday afternoon, I think, and then the following week, we'd gone into a lockdown and I never actually gave the second part of the lecture because by that point the university had shut. That's how fast we entered into lockdown last year, wasn't it? So I hope the next year I'll get to give this lecture in the John Hanbury Lecture Theatre rather than online. But online is how it's going to be. So let's make a start, shall we? We are going to do the lecture in 2 parts, but you'll be pleased to know they are both very small parts because there really isn't a lot of material left to cover. Okay, so that should cheer you up at the start of your last week of term, if nothing else. Yeah. So in part 1, we're going to look at glucose, why it's a problem and why your body wants to get rid of it. We're going to consider how patients develop diabetes in the first place, at least type 2 diabetes. We're going to consider briefly. And that means we might think about how patients can control type 2 diabetes through their diet. We'll mention briefly drug therapies for glucose control. I'm not going to go into it in great detail because really we're focused on the pharmaceutics of insulin here. And I know there's lots of lectures about diabetes by other members of staff. And then before the break, we're going to look at how insulin is delivered by injection and by pens. We'll have a little break. And when we come back again, we'll look at some of the more fancy ways insulin is being delivered. So that would be things like pumps would be a good one. And inhalable insulin. We're going to finish by looking at a couple of inhalable insulins, which I think is fair to say has been an unmitigated disaster. Yeah. So we'll have a look briefly at why that is. Okay, so that's my plan. If you're okay with that, then I think we should make a start. So the first thing we're going to consider is what actually is the problem with glucose. If you think about diabetes, it's a response to insulin, or at least a lack of response to insulin, right? So it's a kind of insulin sensitivity. What is insulin's role in the body? It is to get glucose out of the bloodstream. So one thing you might have asked yourself is, well, if glucose is such a wonder molecule, and it's the molecule that we burn to create energy, why would we not want glucose circulating in our blood all the time? Surely that's the best option, to have lots of glucose circulating in our blood. And then if we feel a sudden need to run away from something or we need to burn some fuel for energy, every cell has a ready supply of glucose in the bloodstream, right? Why do we need insulin to tell cells to burn glucose? There must be a reason why your body wants to get glucose out of the bloodstream, in other words. The answer is because glucose is a really, really reactive molecule. It's a 6-carbon organic molecule. And it will react with almost anything in the body. Doesn't matter whether it's an enzyme, a peptide, whatever it is, glucose will react with it. And when it reacts with it, it reacts by chemically binding to a molecule, and it forms products called advanced glycation end products, or AGEs. I think AGE is quite a good acronym actually, because one of the side effects of a build-up of these products is that you can prematurely age. So it's kind of ironic that. So one way to remember what glucose does in the body is it causes AGEs, and that causes aging. That's one way to remember that, yeah. So AGEs have a number of consequences in the body. I think you might imagine that most biochemical species are exquisitely designed to do something. It doesn't matter if it's an enzyme or something like that. It has a really tightly controlled structure. Every time your body makes one of these molecules, it makes it exactly the same. And it needs to be exactly the same. And you can have a genetic defect which causes, say, 1-point mutation in an amino acid sequence, and all of a sudden your enzyme doesn't work anymore. So I hope you can see that if you then bind glucose onto the end of one of these molecules, that can also stop it from functioning. So one of the consequences of a build-up of glucose is that it will travel around the body looking for things to react with, and it's simply a matter of time before that glucose reacts with something. And the strong likelihood is that when it reacts with something, it irreversibly damages the molecule it's reacted with. So that's one thing. Another thing, it's related really, is if the glucose binds to a lipid rather than a peptide or an enzyme or something like that. If it binds to a lipid, remember that lipids are in cell membranes and there's a mixture of lipids and they're designed to be fluid. So the membrane itself is fluid. One of the consequences of binding glucose to lipids is that the lipid itself then can't act like a fluid, and so it tends to be stiff. And so when you've got a membrane made up of lipids and some of them are glycolated, then the membrane itself becomes stiff. And so stiffening of arterial walls, for instance, and also the preventing of an arterial wall from dilating by giving nitrous oxide are well-known consequences of the build-up of ages. So that's not good. And there are some other ones listed on the screen, increasing vascular permeability and encouraging the release of inflammatory cytokines. And all of these things are really bad side effects of allowing glucose to circulate in your blood for an extended period of time. If you think about some of the consequences of having diabetes for a considerable period of time, and I mean uncontrolled diabetes really, then you are going to get, say, poor circulation to the periphery. You might have eye problems, kidney problems. There's a whole series of problems that can rise from long-term diabetes, isn't there? And these long-term problems all stem from these age products and the glycolation of things with glucose. So one of the things that should tell you is, well, glucose probably isn't quite the wonder molecule that we all think it is. It's easy to think that glucose is a ready-to-burn fuel and we just have to eat something and we're ready to go and run away from the local tiger or something. But the reality of the situation is you actually don't want glucose circulating in your blood for a long period of time, because if you do, you start to build up some of these ages and they cause a lot of problems. Okay. Now, if you don't believe me that some of these things are a problem, then one way of recognising that they are a problem is to think about how not diabetes is diagnosed, but how well diabetes is being controlled. And you can do that with a HbA1c test, and that is a blood test, and it's looking for glycolated products. So essentially you take a blood sample from someone and you look to see what fraction of the material in the blood sample has been glycolated. Because these glycolation products are so damaging to the body, the more they are there, the worse historic control the patient's had of their blood glucose levels. Okay. This is a picture from diabetes.co.uk, which just shows you how you use HbA1c as an indicator of diabetes control. So you're looking for the percentage of glycolated products, and it correlates to your typical blood glucose level. So if you're starting to get, say, 9-10% of glycolated products, it means that your blood glucose level has consistently been 12, 13, 14 millimoles per litre. So it just gives you an indication how well or badly a patient has been historically controlling their blood glucose level. What are the targets for blood glucose level, I hear you ask? They are set by NICE and they're shown on the screen in front of you. So for type 1 diabetic, adult diabetic that is, they should be aiming for a fasting plasma glucose level between 5 and 7 millimoles per litre when waking, and 4 to 7 millimoles per litre before meals and other times of the day. If you are talking to a patient with type 1 diabetes, then you should advise to measure after meals and aim for a plasma glucose level of 5 to 9 millimoles at least 90 minutes after eating. Okay. For type 1 and type 2 in children and young people, slightly different. Fasting plasma glucose level of 4 to 7 millimoles per litre when waking, 4 to 7 millimoles before meals and at other times of the day. Glucose level of 5 to 9 millimoles after eating, and at least 5 millimoles per litre when driving, because you start to lose concentration if you let that drop. Now, how can you control diabetes? I think it's fair to say that if you've got type 1 diabetes, as we talked about before, that's a hereditary condition where your pancreas is not capable of producing insulin. You have rising blood glucose levels because you don't have insulin in order to get it out of the blood. And so you have to treat that by supplying insulin. There's no question about that. But if you've got type 2 diabetes and a patient comes to you and they say, right, I've been diagnosed with type 2 diabetes, you know, there are a number of reasons why they're probably in that situation in the first place. And the most likely one is Western diet. A Western diet can be very high in carbohydrate. I need to be clear at this point that carbohydrate is glucose. It doesn't matter what type of carbohydrate we're talking about. It can be an indigestible carbohydrate, remembering that your gut bacteria can eat that, of course, all the way through to simple sugars. Carbohydrates are all glucose molecules put together, and when your body degrades carbohydrates, it's degrading it to produce glucose. It's really easy to think, well, I'll eat something that's low in sugar. Maybe I'll have some bread as a sandwich and I'll put some butter on it and stuff. But the bottom line is the bread itself is full of carbohydrate, and that is going to reduce the glucose. It's just going to reduce more slowly. If you eat something that's full of processed sugar, straight sucrose, half of that is glucose, and you're going to absorb it literally minutes after eating it. But if you eat something which has got a more hard to digest carbohydrate form, you won't get the spikes in your blood glucose level. But the bottom line is you are still going to absorb quite a lot of glucose, and so your body is going to be constantly producing insulin. I think, and it is a personal view and you don't have to share it, but I think it's kind of important to think about managing diabetes, type 2 diabetes, through diet. And the easiest way of thinking about that is to try and advise a patient to keep their insulin levels as low as possible. And one way not to do that is to advise patients to graze. I know there's lots of diet advice that says eat meals 6 times a day and keep them regular, or snack or graze throughout the day. But for me at least, grazing means you've constantly got blood glucose. And so you're constantly having to release insulin in order to deal with that glucose. For me, a much better option is to have a period per day when you're not taking glucose in. And so your blood glucose levels should naturally fall. And in response, your body doesn't need to release insulin to deal with it. Okay? This is one of the reasons why intermittent fasting is often recommended for patients with type 2 diabetes, because it's simply giving the body a chance to relax and not produce insulin. One of the consequences of insulin, as I'm sure you know, is that it's like a master hormone. It overrides a lot of the other hormones that your body releases in order to deal with things, maybe appetite suppressant or an indicator of appetite and so on. It doesn't matter what it is. The fact is that insulin tends to override and predominate. And if you don't allow your body a chance not to produce insulin, then that insulin signal is always being heard by cells, and ultimately they will stop listening to it because there's so much of it all the time. So I think intermittent fasting is actually quite a good idea. The second thing on the screen is low carbohydrate diets. I know some of you have just rolled your eyes and thought he's going off about low carbohydrate diet, caveman diet, keto and all that sort of stuff. But I truly believe that low carbohydrate diets are a really good way of managing type 2 diabetes. Personally, I follow a low carbohydrate diet, and I try to keep my carbohydrate intake below 100 grams per day, certainly below 150 grams. And I think that the carbohydrate content of a typical Western diet is too high. Okay, if you then supplement that with the odd snack here or there that's got lots of processed sugars in, you're making the situation a lot worse. So I'm a strong believer that if you were to switch to a low carbohydrate diet, or advise someone to switch to a low carbohydrate diet, in the first instance, before you start looking at drug treatments and insulin injections, you could make a big difference in reversing type 2 diabetes. And I'm sure you're aware there are loads of people who have managed to reverse their type 2 diabetes through diet control. And people think that's some sort of miracle. It's amazing. I've changed my diet and my diabetes has been miraculously cured. But no one ever says, well, hang on a minute, doesn't that mean that the diabetes was caused by your diet in the first place? So for me, diet is most likely to be the main cause of type 2 diabetes, and therefore changing diet is an easy way of remedying it without resorting to treatment. The last one on the screen is calorie restriction. I'm less clear about the idea of calorie restriction, to be honest with you. I think that if you're eating the right sort of food, it really doesn't matter how many calories that you take in. If you take in an excessively high number, 6,000 calories a day, for instance, of course, that is probably going to put you into some sort of energy storage. But for me, at least, calorie restriction isn't the main one. And I think when people consider calorie restricted diets, they think about, right, I'm just going to eat a milkshake for the next 3 weeks, or I'm going to eat broccoli. It doesn't matter what it is. It's not sustainable. It's much better, I think, to talk to someone about changing their diet in a way which is both manageable and sustainable, because that's the only way you're going to get true control, in my opinion at least, of diabetes through diet. However, If that's not possible, then there are some drug treatments that you can use to lower glucose levels. They're shown on the screen. Metformin, I think, is the one that most people have heard of. If I was to ask you which drug treatment would you use for insulin, you'd probably say metformin. And that lowers glucose production by the liver, and it also increases sensitivity of cells to insulin. So it's a bit like trying to reverse the resistance to insulin's message that has occurred. Thiazolidine diones increase the sensitivity of cells to insulin. So again, it's trying to make the cells hear the insulin message. Sulfonylureas increase secretion of insulin by the pancreas. So that's a really good alternative to actually injecting insulin, isn't it? At least your body is producing the insulin. And then meglitinides also stimulate secretion of insulin by the pancreas, but are faster acting. So there are a number of drug treatments that you can try if diet changes aren't working. The last resort, I think, is to inject insulin directly. So if this is an issue of not producing insulin, so type 1 diabetes, no question, adding insulin is the right thing to do. If it's type 2 diabetes and that insulin is being produced because you're constantly eating a diet which is producing too much glucose in your blood, then for me at least, to treat that by adding more insulin is making the situation worse. But nonetheless, there are going to be instances when patients do need to control their blood glucose with added insulin, and the most common way of doing that is with injections, as shown on the screen. There are two types of injections, basal and bolus, and it's kind of important to recognise what they are trying to do. Basal insulin is a type of injection which is mimicking endogenous background insulin production. So imagine that you've always got a small amount of insulin circulating in your blood to keep a constant glucose level. Then the idea of a basal injection is maybe once a day, long-acting insulin, and we talked about those last week, remember. Then you would inject that once a day, you get a background level, slowly release the insulin just to keep the blood glucose levels under control. But imagine that you were to eat something and your pancreas was functioning normally. In response to eating, the pancreas would produce insulin. And so the idea of a bolus injection of insulin is that you inject that as a bolus is the word, isn't it? But so a reservoir of insulin, and now you want fast acting insulin. So you want it to dissolve relatively quickly over the course of an hour, say, after eating, because it's designed to mimic the endogenous response of your pancreas to food intake. Okay, so two different types of insulins, and it's really important to talk to a patient and make sure they understand what the difference is between those two types of injection. If we think about insulin regimens, there are two types that you might counsel a patient to do. Those would be a fixed regime and a flexible regime. So the advantages and disadvantages of both are shown on the screen. For a fixed regime, same dose and type of insulin every day. So the patient doesn't have to think about it. They know what they're doing because it's the same thing every day. But they have to think about what they're eating. So if they're injecting the same insulin at the same time every day, they can't then go and eat a pizza halfway through between two injections, because they don't have that natural response to food intake. It's the same level of insulin all the time, and so they've got to be really careful with what they eat. On the other hand, if someone has a flexible regime, it means that they can give themselves different types of insulin at different doses at different times of day, and they can be much more variable in how they choose to eat. But they have to remember what insulin they need to give themselves in response to what they've eaten. So if they eat something really carb heavy, for instance, then they need to remember to give themselves a bolus injection pretty quickly. Okay, so it's really about assessing the competency and understanding of the patient, that they understand what it is they need to do in response to how they're choosing to eat. If you do give insulin for injection, there are some considerations for the patient. So one is that insulin is always supplied in solution. The concentration, as we talked about last week, is in international units per mil. And I noted before, for human insulin, it's 1 international unit is 0.035 milligrams of human insulin. So a typical dose for injection may be, say, 100, 200, 300 IUs per mil. 100 IU per mil is equivalent to 3.5 milligrams of human insulin. If it is porcine or bovine insulin, as we looked at last week, that number changes slightly. because the amino acid sequence was different. Not a lot, but it changes a little bit. And the reason this is on the screen is because when we look at the inhaled insulins at the end of the lecture, one of the main issues with why one of those products failed was because rather than giving the patients the product in international units, it was given in milligrams. And so patients had to convert between those two units, and they didn't really know how to. So I'm showing you how to right now. 100 IU is equivalent to 3.5 milligrams of human insulin. You can adjust the dose by varying the volume of insulin that you are injecting, and the syringe is calibrated for your particular dose. And the key thing, I think, for needles is that the patient has to have training in how to use the needles, and they also have to know how to dispose of them, and they have to have a proper sharp spin. So there's a degree of management training around using needles, which makes it a little bit tricky. What that means is that pens and cartridges are becoming way more popular with patients. So some are shown on the screen in front of you. They are much easier to use for the patient than vials, syringes and needles. You can carry them around in a coat pocket or your handbag or something like that, and they look quite discreet. They are reusable, but you need a new needle each time. And when I say reusable, I mean you can put in a new cartridge of insulin and use it that way, and or one cartridge can be used to provide multiple doses of insulin. You just have to know how many IU are in the cartridge, and you have to know how much you are injecting each time. The cartridges themselves can contain somewhere between 1.5 and 3 mils of insulin suspension, and the dose itself is user defined. So the user can say, right, this is the dose that I want to give myself right now. They can rotate the end of the pen, and they can set the dose themselves, and then they can inject whatever they want. So it's not the same dose every time if they don't want it to be. And each particular cartridge can last up to 4 weeks. It's a really user-friendly type of system, I think. More recently, especially in the US, and we might come back to that in just a second, pens have been approved with much larger dose capacities. So some of them are shown on the screen in front of you. Humulin RU500, funnily enough, contains 500 IU per mil dose. It's a 3 ml cartridge, so it contains 1500 IU in total. And it can deliver up to 300 IU in a single dose. That was approved by the FDA in 2016. There's another one at the bottom there. 2JO Max Solar Star is insulin glargine, 300 IUs per mil, 900 in total because it's a 3 ml cartridge, up to 160 IU in a single dose. That's FDA approved in 2018. You might say to me, okay, why are these pens being delivered with these really large doses, sir? It doesn't seem like a good thing. And I agree with you. And the answer is, if you think about what your pancreas is doing, it's producing insulin in response to glucose intake. And type 2 diabetes has occurred because your cells are becoming resistant to the message of constantly being surrounded by insulin. If you then start injecting insulin in addition to the insulin that your pancreas is producing, and your diet hasn't changed, what is the consequence of that? The consequence is that the insulin resistance is going to get worse, isn't it? Because for your cells, they don't know whether the insulin is coming from your pancreas or from a pen. And so the problem of sensitivity gets worse. This is one of the reasons why I think controlling type 2 diabetes through diet is way, way more important than simply starting someone on an insulin regime. And the fact that the US in particular is now approving these very high dose insulin pens is kind of an indication that insulin treatment for type 2 diabetes isn't working. It's actually making the problem worse. So that's something I think it's worth you having a think about, because if you're going to counsel a patient about this, you have to have some difficult conversations. And one of those difficult conversations is to say, look, we need to talk about your diet, because if there's too many carbohydrates in the diet, this problem is not going to resolve itself, and medication probably isn't the answer. Okay? Right, with that thought, I see that my coffee has gone cold and run out, so that's not very good. So it's time to stop, and when we come back, we'll finish the lecture by looking at some of the more novel ways in which insulin can be delivered. So I'll see you in a bit.